thank you for that. That was a very interesting overview of motor neurone disease and some of the reasons why we don't have the answers that we'd all really love to have. So I'm opening the floor now to questions. If anyone would like to ask a question, if you can wave around or whatever, and there are some microphones that will come to you. So anyone with a question?
My question relates to statin drugs and the effects that it has on the process of motor neuron.
Statins are very widely used drugs that appear to have benefits in a number of conditions, and there's certainly some evidence that they may be beneficial in Alzheimer's disease. I think the evidence in motor neurone disease is a little bit slim at the moment. I think that more research needs to be done on it, but I think that the possibility of that being a beneficial thing is quite reasonable.
I was told by somebody that it could actually speed up the effects. Would that be correct?
I'm not aware of that. Do you know what the mechanism of that is thought to be?
No, I don't. No.
Well, certainly there is some evidence that other degenerative processes can be slowed down. So when particular hypotheses begin to be tested, it's not uncommon to have conflicting information about it. So I think that's one of those things where the scientific papers always end up with more studies are required. Sorry, it's not definitive just at the moment.
Okay, another question?
What has been the success rate of the use of Botox in the legs? And another quick one, does sleep apnea have any correlation to MND?
Okay, so the first question is whether Botox has been helpful in the legs. Is that correct?
Yes.
Yeah. Botox is a very powerful toxin that blocks the messages that go to the muscle. So you would at first think that that's not a particularly useful thing to use when the problem is weakness. But if the weakness is due predominantly to problems with the upper motor neuron, then what may be happening in the legs is there's stiffness rather than weakness. And the use of Botox in that situation can reduce the stiffness, and if it doesn't produce too much weakness, it may benefit the patient overall. But it's one of those things where there's a real balance problem, that you have to use enough to reduce the spasticity, but not so much that you increase the weakness. So it's very much an answer for an individual patient, and typically it will only be a useful answer for a period of time, not continuously. So that was the first question, and the second question was?
Sleep apnea.
Oh, sleep apnea and the relationship to motor neuron disease. Sleep apnea is very common. I'm not aware of any evidence that sleep apnea makes motor neuron disease more likely. When patients have motor neuron disease, if they develop weakness about the muscles of the pharynx or the jaw or the tongue, then potentially they can get more blockage of the airway at night time, and their night breathing can be impaired. So there are a couple of reasons that breathing in patients with motor neuron disease at night time may be suboptimal, and one of them is the possibility of developing sleep apnea. So I think it's a sensible thing to have some sort of investigation of sleep breathing in anyone with motor neuron disease, because treatment of that is undoubtedly effective in improving quality of life, and it almost certainly increases longevity as well, because it helps to rest the breathing muscles at night time.
Okay, you might have a couple of written questions that people have put in as well, so I'll put them in between. So, with lower motor neuron disease, are there side effects that cause severe red or purple discoloration and swelling of the ankles and lower legs?
What I say to my patients is that human beings are designed to move, And if you stay still for any reason, things begin to go amiss. If you've been on a long-haul flight, you know, you get off the flight and you can't put your shoes on properly because your feet are swollen. The reason that that happens is because part of the process for returning blood to the heart is muscular contraction, which squeezes the veins and returns blood to the heart in that way. So when you have lower motor neuron weakness, your capacity to squeeze the veins and to squeeze the lymphatic vessels and to return blood to the heart is diminished. That blood tends to sit, and then the fluid leaks out into the tissues. You get swelling, and you can certainly get discoloration. So it's not a specific effect with motor neuron disease, but it is related to relative inactivity. The easiest way to deal with that is to keep the limb up so that you employ gravity to try and reduce the swelling in that way.
Another question from the floor?
We have some concerns in regards to using the riluzole. Just relating to, you stated that there were 4 causes that could destroy a nerve. If you're taking the riluzole thinking it's that cause, it's not, it's one of the other 3. Is taking the riluzole going to create other problems?
The way that I'd answer that question is to talk about risks and benefits. And the problem with any medication is that all medications have side effects. So in any decision to take a medication, what you're trying to do is to balance the benefits that you get against any particular side effects. And obviously the side effect that you're concerned about here is a serious one, that it might actually accelerate the disease process. I don't think that there's good evidence that it can accelerate the process. Now, that doesn't mean that it can't, but when you don't have any evidence, it's more prudent to decide in favour of whatever benefits you might get from that medication. So, were there a proportion of patients who deteriorated as a result of using riluzole, that would make the trials that have been done on riluzole less likely to be positive. In other words, it wouldn't have been recognised to be effective. So that's a hint that riluzole is overall more effective than it is harmful. But the specific question about an individual patient is actually impossible to answer. So I think the only answer that I could give to you in that situation would be the risk isn't zero, but from what I understand of the process, it's so low that that wouldn't be a decision that would lead me not to take the riluzole.
Okay, we'll take another one of these questions. I would like to know where the phase 3 trial of dexpramipexole is at. That is, how viable is it as a treatment, and when would it be available to MND sufferers in Australia?
That's certainly going ahead. I spoke with Matthew Kiernan in June. He was actually expecting an announcement relatively soon as far as the results of the phase 3 trial are concerned, and the initial signs would be that it's positive. From that stage to its becoming available is a very variable process because there are regulatory authorities in Australia that have to decide that that's an appropriate medication to be available here. People can obtain medication on an individual use basis from overseas. So it depends on whether the study is positive, and then whether the FDA in the United States approves its use, and then whether or not you're talking about individual patient use from medication overseas, or whether you wait until it becomes approved for use in Australia. So we're still talking about a significant period of time, unfortunately. I think that's probably as accurate as I can be with that answer.
On over here.
I was diagnosed with MND 2010. I haven't progressed any further. I was just wondering, I get very bad cramping and fistulation, very bad. I get very tired. And yet you see that as a slow progress in children. I'm 70. Would that be?
Okay. So far, what I understood you to say that you were diagnosed in 2010, and although you've got significant symptoms, you don't feel that you've progressed since that time, and you think that's a little bit unusual, given that slow progression is more usually associated with younger onset. Well, the answer to that is that there's a bigger overlap. And you can certainly have adult onset motor neurone disease which is slowly progressive. And I believe that you can also have forms of motor neurone disease which plateau. So the photograph of the lady's hands that I showed you was a photograph of a lady that, to the best of my knowledge, had plateaued for something like 10 to 12 years. So while that's uncommon, it's something that at least provides a little bit of optimism. So perhaps your situation is simply a very fortunate one, but there is a big overlap as far as the progression of the disease is concerned.
Just got a question to follow on from that. So if you've got a slowly progressive form of motor neurone disease, does that mean that as you progress, that you'll progress slowly all the way through?
As far as we know, the rate of progression doesn't change as time goes by. So if it's clear that things are progressing slowly, there's no reason to expect that that will alter.
Next question over here.
Just getting back to your question about swollen legs. Support stockings, is there any role for that?
Look, there are a range of things that can be done to assist. So elevation is the simplest one. There are lymphatic massage that some physiotherapists are expert in. That can certainly help. Support stockings will certainly help the area where the stocking is, but you can then get swelling above that level, depending on how high the stockings actually come. They're probably more useful in preventing rather than treating the swelling. So if you have your legs elevated, massage, reduce them and then put the stockings on, that's probably the best way to use them.
So then a DVT is an issue?
The question is whether DVT is an issue. DVT is deep venous thrombosis, so it's a blood clot in the veins of the legs. Surprisingly, that does not seem to be a common problem in patients with motor neurone disease. Whether there's some protective component or whether it's just that they don't have clotting problems as such, I don't know, but it's surprisingly uncommon as a complication of motor neurone disease.
Take another one of the written questions. We've noticed significant personality changes in our relative with MND. Is this something related to MND? And if so, how much is known about psychological changes and the link with MND, and are there any treatments?
I think the first thing that I would say is that any significant diagnosis has potential impact both emotionally and on people's typical ways of coping. So at first I would at least consider the possibility that it's the diagnosis itself having an impact on the way in which the patient normally behaves. Having said that, there are forms of motor system degeneration, which can also be associated with changes in cognition, changes in thinking and memory. These are relatively rare, but it's possible that this relative has a variant of motor neuron disease where the normal sparing of thinking and memory doesn't occur. It's hard to be any more specific than that with the information that we've got.
Another question from the floor? This one, no. We'll give you another one.
The causes of MND that aren't genetic, like exposure to any toxins or heavy metals, such as like copper, maybe?
So the question is about the causes of motor neuron disease which are not genetically determined. So it's a slightly complex answer because the first thing that you have to do is to separate out those conditions which we know are different to motor neuron disease but are caused by toxins or heavy metals. So for example, lead toxicity, that's one that we know a good deal about. Lead toxicity causes a motor neuropathy. Now, if you're not a skilled neurologist, a motor neuropathy may look very similar to motor neuron disease, but before we diagnose motor neuron disease, what we do is to look for those sorts of problems because we know they're separate diseases and that they have a different treatment. So, for example, lead poisoning can be treated with chelation therapy. So, yes, lead can cause a problem that's similar to motor neuron disease, but there's no evidence that lead causes motor neuron disease. And if we extend that, for other heavy metals, the same thing is true. Over the years, and I do mean over 100 years or more, environmental factors have been investigated uphill and down dale to find those things which might be contributing to development of motor neuron disease. And to date, none have been identified. So at this stage, we don't have any absolutely confirmed environmental factors. So at this stage, that's the best we can answer, unfortunately.
You said that a lot of older people get it, like my wife's quite young, but you're saying about lead. All the houses used to be painted, there's lead in paint, and there's no lead in paint now, but all the houses in the old days were painted with lead.
So I'm sorry, that's a comment or a question?
Well, that's what I'm trying to just add to what we're talking about, like you're saying, this gentleman asked about lead.
Yep.
And I was just saying, you said that a lot of older people earlier that have got motor neuron disease and they weren't diagnosed. Well, I don't know, it might be linked to, in a small way, to houses were all painted with lead, like in the paint.
Well, lead's a universal pollutant. It occurs everywhere, so it's not just in house paint. Studies that have been done show that there was no lead pollution prior to the Romans about 2,000 years ago, so we can blame the Italians for this. Since then, lead is everywhere as a pollutant. Exposure through lead paint and through other things can produce increased amounts, but it's relatively straightforward to test for it and also to treat it. So if anyone has any concerns, that is something that should be able to be sorted out fairly quickly.
From hearing what you were saying about elderly people and MND, and comment, of course, about familial problems, I wonder, in fact, how many elderly people may die of MND, which is in fact diagnosed. They develop it at a time in their life when people generally accept that weaknesses occur, and your physician for people like that may not be particularly interested in pursuing neurological investigation. And everybody, in fact, is asked the question, has anybody in your family suffered from it? And thinking back in my own family, I can think of 2 or 3 of my elderly relatives who developed weakness. And I say to myself now, well, maybe is it likely?
Yes, it's a very valid point. And just to summarise it, the issue is this problem of underdiagnosis of motor neurone disease in older folk. The first thing that you need to do in order to get a diagnosis is that you need to go to the doctor and make a complaint. And if you're becoming slowly weaker, particularly if it's very slow, and you're 85 or 90, and you think, well, I'm 85 or 90, yeah, I used to be stronger, but now I'm not. Well, that's just the way it goes, isn't it? So you don't go and complain about it. So I think as people get older, the issue is that they tend not to present. And if they do present, you've got an overworked general practitioner who looks at this elderly man who says, I'm feeling a little bit weak. And he says, well, gosh, you know, you've been a smoker and you've got lung disease and you've got this and you've got that. I'm sure that's the reason. Off you go. So there's a tendency to under-investigate older folk as well. That's declining, and that's why we're seeing, part of the reason I think we're seeing more elderly folk diagnosed. It's still only small numbers. I mean, there aren't that many nonagenarians around. It's the risk that's increased rather than there being large numbers of them.
I've got a few questions here related to hereditary nature of motor neurone disease. One is asking just how true is it that it can be hereditary, and if so, what should we be telling our relatives?
It's unequivocal that some forms of motor neurone disease are inherited. What should you tell your relatives? Well, it depends which relatives we're talking about. And the most important ones usually are your children, if you have this particular form of motor neurone disease. What I ask people to think about in that situation is the typical age of onset of motor neurone disease, how old their children are, and what sort of progress might be imagined over the period between their age and the typical onset of motor neurone disease. So when you think about it in those terms, if you've got someone, for argument's sake, who is 60 years of age, who has motor neurone disease, and is concerned that it might be familial but doesn't have any evidence that that's the case, I would think that that's probably not something that children need to be burdened with. If there is a family history, then that's certainly something that needs to be discussed. But the risk that that poses to children is determined by what form of inherited disease it is, and the ages, the age of onset and the age of the child. And I think one of the things that people tend to overlook is that the risk to their children is something that's 20 or 30 years down the track, by which time I think there are going to be extraordinary changes. The example that I like to use is that when I started in neurology, there was no treatment for multiple sclerosis. Right now, there are 5 different treatments for motor neurone disease. And I'm getting older, but I'm not that old. All that's happened in a relatively short period of time. And I hold out significant hope for degenerative diseases, including motor neurone disease.
And just to clarify, those 5 treatments are for MS. Thought we didn't know something then. And this is another one, that 10% of MND is caused by genetic mutation. So what sort of mode of transmission is it? Is it X-linked, recessive or dominant, and who and where should I approach for genetic testing?
To my knowledge, all of those forms of transmission have been identified in patients with motor system degeneration. The commonest is what's called autosomal dominant transmission, and that's where an affected individual passes on the gene with 50% likelihood to each of their children. So each of their children has a 50% likelihood of having the gene. That doesn't always translate into a 50% risk of developing the disease, but there's a relatively close correlation between those two. In terms of further referral, I would think to Professor Nicholson and Dr. Blair at the Anzac Institute. They are really the experts in that area, and I'm sure they'd be able to answer any questions that you have along those lines.
You can also contact the Motor Neurone Disease Association. We have some information as well. And this is a final one just on the genetics. That this is someone who has sporadic form of motor neurone disease, where their son's wife is due to give birth to twins in September. The question is, should we store their cord blood for future use, or is there a way it can be used for stem cell research? And maybe that's a question for later as well.
I'm sorry, I didn't quite get the relationship between the patient with motor neurone disease and the twins.
So it's the son's wife who's pregnant and the person has sporadic MND.
So we're talking about the grandchildren of someone with sporadic motor neurone disease. Look, at this stage, I don't know of any useful way that the cord blood could be helpful. And I think that the expense of storing a grandchild's blood for that reason would be difficult to justify. But again, I think that's probably something that needs to be discussed in a bit more detail for that specific person.
So any other questions? Anyone that's sitting there holding? Yeah. Okay, there's one just over here.
You may have answered this and I missed it during the lecture, but in regards to the SOD1 gene, the absence of it in the Germans, is there any significance to that?
That table is a number of years old. I'm not sure whether that particular table is accurate still about Germany. It would have been on a small sample initially. The significance of it is relatively minor and probably relates to what's called a founder effect. The founder effect is if you get a new mutation, so for example, someone develops a new mutation for a disease in Tasmania, you will find over time that there's a focus of that particular condition in Tasmania, but much fewer of those patients perhaps in Iceland, because the only way that they would get there is by migration. So it probably relates to migration effects in relation to the initial mutation of the SOD1 gene, rather than being anything more significant than that.
Okay, so are there any other questions? Time for one last one? No. Okay, you must have answered them all. So I'd like to thank Dr. David Williams for his presentation today. It's been very informative, and it's just great to have the opportunity to ask those questions. And we just have a small gift in appreciation for your time and the energy you put into today. So, thank you. So our next speaker is Dr. Ian Blair, who's the Principal Hospital Scientist at the Anzac Research Institute and a Clinical Senior Lecturer at the University of Sydney. Dr. Blair is an internationally recognised researcher in neurogenetics. He is currently a Senior Research Scientist at the Anzac Research Institute, where he heads a group investigating the molecular basis of motor neurone disease. Dr. Blair's research career has focused on determining the molecular molecular basis of a variety of neurological disorders, including ALS. Dr. Blair's scientific achievements include the successful identification of genetic basis of ALS type 4 in motor neuron disease, as well as mapping of another novel MND locus. The identification of ALS4 gene was one of the major breakthroughs that identified the shared genetic link among motor neuron disorders. So Ian's going to talk about what's new in MND genetic research for 30 minutes, and then we'll have 15 minutes for questions. Just find your presentation. Okay, does anyone want to stretch? It's always nice to have an opportunity for a little bit of a stretch. So don't go too far.